Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. I thank you all for joining us today and our friends at Lynn Community Health Center for hosting today's session, Dermatology, a Case-Based Approach with Dr. Stacy Salob. And with that, I'm going to turn it right over to her so we can get started.
Okay. Thank you very much. I'm a dermatologist in private practice in New York City, but I also do a lot of teaching at Cornell, where I do monthly sessions with the residents and medical students that are rotating and teach them in clinic. And I've been involved with MAVEN now a couple of years. And so what I pulled together today is just some basic didactic information and then some cases, and they're all based on cases that I see that have come up through the MAVEN consults. Disclosures, the accreditation, our objectives today are really basic. We're going to just spend a moment going over description. One of the things I've noticed when I've been doing MAVEN consults is you guys try really hard to think things through before you ask us a consult. You try to describe what you're seeing as best you can, think about a differential diagnosis. And dermatology has its own vocabulary. It's almost like speaking a foreign language. And so I'm going to try to help you improve your conversational skills in dermatology. We're going to look at a few cases. My philosophy is that I could sit here and just talk to you, but if I challenge you with looking and thinking about a case and you're a little interactive and engaged, you're more likely to get something out of it. And we'll talk briefly about treatment of different things. I think when you're thinking about a large field like dermatology, where there's over 2,000 different diagnoses, you can think of having a scaffolding or a schematic where you can, as you gather information, you can kind of place it in your brain, helps you kind of organize it. And that also helps you start to think about different conditions. So if you think of this scaffolding as a tree of dermatologic disorders, on the left first branch, you see various inflammatory things, which are divided into infectious and not infectious things. Infections can be fungus, tinea, bacterial infections like impetigo, viruses like herpes. And non-infectious things can be pink scaly things, hive-like things, autoimmune things, and blistering things. Versus neoplastic, is this growth benign or is it malignant? And then there's other more rare things such as metabolic, nutritional things, genodermatoses that we think of. So as we're looking at these cases, think about where on this schematic that you're developing in your brain you're going to put these individual conditions. Dermatologists spend a lot of time thinking about pathology. We do a lot of biopsies of things to understand more about them, both in terms of growth, are they benign and malignant, and in terms of rashes. And when we're looking at their skin, we're really looking at the gross pathology. And then we are interested to see what the pathologist thinks about the microscopic pathology. When we're looking at lesions, we're thinking about what level in the skin is the problem? What's causing it to be raised up as a bump? Where are things separating to make it a blister? So just to, I know you guys all looked at this at some point in school, but just to look at it again, our top layer of skin is called the epidermis. It is separated from the dermis, which is the support structures with the collagen and elastic fibers, by what's called the basement membrane. There's a lot of active research in the basement membrane because this is the glue that's keeping things together. It makes sense, always made sense to me if you're designing the skin that rather than having this be flat like a sheet of paper, you want to have it undulate up and down just to have extra glue points to keep things glued together. And then at the bottom is the subcutaneous tissue or the fat layer. We have blood vessels that run through the dermis. We have in the blue is a schematic of a sweat gland, and the brown is a schematic of a hair follicle. The oil glands come into the hair follicle. There's a cute little muscle called the erectile muscle, but that's what gives us goosebumps when that is tightened. It's kind of our only muscle. We have nerves running through here, so there's a lot of action going on to think about it. Okay, so vocabulary. Let's run through this quickly. Things that are flat, if they're less than a centimeter, we call them a macule. They're greater than a centimeter, we call them a patch. If you close your eyes and run your finger through it, you shouldn't feel the spot. If something is elevated and it's small, we call it a papule. If it's a little bit larger than a centimeter, we call it a plaque. And if it's a big juicy thing, we call it a nodule, like a big cyst, for example. And then blisters are called vesicles if they're small, and bullae if they're large. So let's look at some examples of this. So on the top, you would see, and here's our schematic of a macule. Here's an example of lentigines, which are liver spots or sun freckles. A larger patch might be this patch on the right here of vitiligo. And then the example they're giving here of something elevated, a papule, is a seborrheic keratosis. Again, you run your hand over it, you're going to feel it. A larger plaque would be an example of psoriasis, or here they have keloids and acne scarring. Deeper things like these cysts, these are epidermal inclusion cysts, would be nodules. And blisters, like you might see group little blisters in a herpes infection, such as herpes zoster. We can get more descriptive. When I used to work in academia, the residents would go into the emergency room and they would call me, and I have to try to make a mental picture of what they were seeing in order to help them. And so the more words, descriptive words they could use to describe things, the better. So if we're looking at a raised spot, it might be flat topped. An example of this would be lichen planus, where we have flat top papules. It might be dome shaped, like this basal cell cancer sitting here. It might be filiform, like tiny little warts sort of sticking up. It might be pedunculated, where it's the part touching the skin is very small, like a skin tag, which is so common. It can be smooth, such as a dermal nevus here, or a verrucous, such as warts, or umbilicated, such as molluscum, sebaceous hyperplasia. Other changes you can talk about. Is it crusty? Something, some secondarily infected eczema can have crust on it. Is it scaly? All of the psoriasis, eczema conditions can be, tinea can be scaly. Are there little fissures in the skin? That's not good. That's pretty painful. Is the skin eroded, meaning that we're missing a part of the epidermis, or is it truly ulcerated, such as this vasculitis, where the damage to the blood vessels is leading to open skin? Is the patient scratching? Are we seeing signs of scratching, called an excoriation? Is there atrophy? This shows stretch marks. Have we abused the privilege of using topical steroids or used the wrong ones? Is it lichenified, where you see this pronounced thickening of the skin, which suggests it's been going on for a while, and the patient's super itchy, and they're rubbing, and the skin is reacting and becoming thicker? Some more examples on the left. This is neurofibromatosis with the cafe au lait patches. So you see smaller macules and patches. On the right is vitiligo. On the left is a dermal nevus, an elevated dome-shaped papule. On the right is a plaque of psoriasis, a very well circumscribed erythematous plaque with whitish or silvery scale. Here are some vesicles, smaller blisters, and very large villi here. We're going to look at this one again if we have time. And here's nodules and a ganglion cyst, a big, juicy, deep. Okay, so I brought some cases today. I'm going to describe them, and I would love your input as to what you think it might be. So here we have this young, otherwise healthy male, and he has this rash that's spreading pretty rapidly of 1 week's duration. He's coming in on an emergency visit, and the photos show you the trunk. It shows you the most of the back, and shows you part of the abdomen. On the abdomen, you see one larger patch or thin plaque with scale. The erythema is a pretty pinkish red, not a truly bright red, and there's some scale with some central clearing. And then there's multiple smaller lesions. They're sort of round to oval in size. And again, they have some fine scale on them. On the back, the lesions are of various sizes. Most of them are about 1 centimeter. Again, these thin plaques with some scale. They're sort of in a round to oval, and they're all pretty discrete. It doesn't look like they're coming together. You guys have any idea what this might be? Pityriasis rosea. Well done. So pityriasis rosea is actually one of my favorite rashes. It was the very first dermatology diagnosis I ever made when I was in med school. My then boyfriend, now husband, came down with this, and I searched through the atlas, and I'm like, this is what you have. It's benign. It's self-limited. It usually lasts. It can last as long as 2 months, which freaks people out. But at least it's not chronic, like conditions like atopic dermatitis and psoriasis. Somebody mentioned a Herald patch, which doesn't always happen. When it does, it's super helpful. So probably this larger and plaque on the abdomen was the Harrell patch, and the patient might say that it started there, and then a few days later it started exploding um, all all over all over the skin. If I'm smart enough, when I'm seeing the solitary patch in the office, I say, "Oh, this is probably just a little patch of eczema," but there's this condition, pityriasis rosea, where it's suddenly within a week or two it explodes all over your body. Don't panic if that happens. You don't have to call me at 3 in the morning. You can wait to call me the next morning, and we'll go over it. We think this is a post-viral condition, but only about a quarter of people report a preceding or concurrent virus. Most are asymptomatic. But one of the things at least to me, we've learned with COVID is just how often you can be asymptomatic and have a viral infection. So the fact that only 25% of people report having had a virus doesn't bother me at all. I apologize, I'm frozen somehow. I apologize. For some reason my computer is frozen. Oh, there we go. Um, uh, Rashes can look different in skin of color, so it's important to also look at photos of skin of color. This is pityriasis rosea in a patient with more melanin in their skin. And because of that increase in melanin, you don't see the redness as easily on skin of color. So, but what you do see, these same round to oval, scaly patches or thin plaques. Sometimes there's a little bit of central clearing. And this patient demonstrates even better than our original patient that sometimes these patches will line up along the lines of relaxed skin tension, which on the back has been referred to as a Christmas tree because it can kind of go diagonally. There's two differentials when you are thinking, I've got classic pityriasis rosea that need to go through your head. This is secondary syphilis, and it can look very much like pityriasis rosea. I show you here on Caucasian skin, but also in skin of color. We're seeing these pinkish, round to oval, scaly patches kind of distributed mostly on the trunk. And so and sometimes it can be tough to differentiate. You don't always get that perfect Christmas tree. You don't always get that. That Herald patch. You can try to look in other places to see if there are other stigmata of secondary syphilis. For example, you can get mucus patches on the tongue. Syphilis often has palm involvement. You can look in the genital area where you might see these moist papules of condyloma lata, and you can see moth-eaten alopecia on the scalp. But you might not have any of these. You might just have the rash. So in my earlier career, everybody got screening for syphilis. I've only had one positive in my whole career, but it was when I was a resident. It was a temporary nurse in the clinic who, at the end of the clinic, raised her shirt, said, "Rash." I said, "Oh, we get this on everybody," and she's been the only positive. But depending on where you work and what your clinic population is, this might be more significant. So whenever you're thinking about pityriasis rosea, think about syphilis. I'm now more nuanced. I practice in the Upper East Side of Manhattan, and patients don't always want me to just routinely get this. They want to have a conversation about it. So I ask, but you need to think about it because syphilis is very much on the rise. The other thing is that there's a drug rash can present as being pityriasis rosea-like. And so, I often will also take a look at patients' medications and try to think through, is anything new? Has anything been changed? These are some notes from a paper on a dermatology online journal of a pityriasis rosea-like drug or action. And they were trying to differentiate what could help you from the classic pityriasis rosea. They mentioned that their patient did not have that characteristic peroral patch. They tried to differentiate the color of the spots, but I don't know how helpful that is. They tend to be brighter because you can have eosinophils in a drug rash. The patients with a pityriasis rosea-like drug rash tend to be itchier. And so, whereas classic pityriasis rosea tends to be, yeah, kind of itchy, maybe not. And they get better a little faster if you take away their medications. And ACE inhibitors seem to be the most common, but it's been reported with so many different medications, various antibiotics, NSAIDs, omeprazole, even just vaccines. So it is something to at least think about. And if you're suspicious about a drug rash and you're able to stop what they're using, then you do better. So just to summarize, this is more common in young adults. It happens to also be more common this time of year in spring and summer. I'm not sure why. It can start with that Harrell patch, and then it becomes more widespread over the next 1 to 3 weeks. So the sudden rash is really freaks patients out. It tends to be more the trunk, neck area, but you can get it on the face and anywhere else. Only a quarter of patients have that viral prodrome. It can take a couple of months to resolve, but it does. Treatment doesn't seem to make a difference. So it's really just for some symptomatic relief. Anytime patients in skin of color have a rash, they're vulnerable to healing with post-inflammatory pigmentation. So I do warn them to be real careful in the sun. And then just to think about that, especially that secondary syphilis as well as a PR-like option. All right, let's keep going. Case number 2. This is a 32-year-old, otherwise healthy guy who has a very, very itchy rash. He's really miserable of at least 3 weeks duration, and it's spreading. So you see here on the trunk, you see erythematous papules. They are dome-shaped. They don't seem to have a whole lot of surface change, at least on this picture. But the surrounding skin doesn't look normal either. There's a little bit of erythema. There are these linear lesions here that probably suggest excoriations. They're a tiny bit crusted. So the fact that he's saying it's extremely itchy is certainly validated by his appearance. Do you guys have, I'll show you more pictures as we go that will help you, but do you have any ideas, at least in a differential, to think about what this might be? Oh, somebody said scabies. Well done. So this is scabies. Scabies can present with some pretty juicy papules and even small nodules, and it's extremely itchy and extremely contagious. Apologize, guys. Another case of scabies, ill-defined. This doesn't, you don't see burrows here. You see these little pink scaly thin plaques, but crazy excoriated. This is super duper itchy. If I showed you this, I think you all would have gotten it right away, because this is a place when you're thinking about scabies to look for little papules and a little bit of scale and these very classic little burrows. I use my tool is instead of a stethoscope, I use a dermatoscope, which has 24 beams of light that gives us a lot of extra information about what's going on in the skin. I have seen some MAVEN consults where they're trying to look at things with a dermatoscope. And if you have one, for me, this has been a game changer in scabies. The average person has 12 mites on their skin. So a lot of what we're seeing on the skin is old stuff. The little scabies mites are laying eggs. They're pooping, and the patient's immune system is reacting to that. This is before dermoscopy, we would scrape multiple little spots. We'd go on a hunt for burrows and would try to look under the microscope for but the scabies mite, but dermoscopy has changed that for me. So this is an example of a dermatoscope. It's handheld. We bring it just like a millimeter or two above the skin. And this is the tiny little scabies mite. And this little scaly bit here is her burrow. Here's another schematic. She looks like a tiny little triangle. We're seeing her head on. Here's her little burrow. And at the top here, you can actually see some eggs that she's laid. This is described as being like a delta wing because we're on the right is the example of the plume of a fighter jet, and on the left is actually our scabies mite looked at under the dermatoscope, so you can see where that analogy came from. Scabies mites are not after a blood meal. They want to eat the dead keratin in our top layer of skin, the stratum corneum, and so they burrow. It's where they lay their eggs. If you are finding a mite, by definition, it is a female mite. The guys just um, uh, uh, have an interaction with the ladies, and then off they go. This is what the mite looks like. It's got, she's very round. She's got 8 legs, 4 in the front, 4 in the back. She can move about a centimeter in an hour, so she can really be on the go. She is less than a millimeter. You cannot see her with your naked eye. This is her life cycle. So she copulates with the guy, he goes off. She starts burrowing and laying her eggs. The eggs, within 2 or 3 days, hatch to larvae. They come back up to the skin. They go back down, and within a week, we've got another adult mite ready to go. The treatment for this is you have 2 main options. One is topical, one is oral, and you can always combine them. So the topical is permethrin. The scabies mites do not like parts of the skin with oil glands, so we treat from the neck down. The exception with that is children and infants, because they are prepubertal and they don't have active oil glands. So for there, we'll treat the face and the scalp. I'm very, very explicit when I prescribe this to treat from the neck down, to make sure you're getting between the fingers, between the toes, that you are treating the genital area, because it's a place that mites happen to like to be, that they apply it that night and wash it off in the morning, and they repeat it in a week. The reason to repeat it is that although it kills the live mites, it does not kill the eggs. And so knowing this life cycle, you want to repeat it in a week when the eggs that she might have recently laid have hatched. The other option that you have is oral ivermectin, which is dose based on weight. Again, you give 1 dose and repeat it in a week, because it's not quite as ovicidal as we like. Knowing that the mites are wanting to live in the top layer of skin, the stratum corneum, and they are eating keratin, one of the ways our body is trying to get rid of them is to shed them off. And they have something to eat for a little while, because they have, we're shedding them along with their food source. So there definitely have been a number of patients where you're like, just not getting them better. They're not clearing. They seem to be compliant with their treatment. And we think it's maybe because of fomites in their bedding or their household or their clothing, that they just keep reinfecting themselves. And of course, the concern about reinfecting others. So the tradition has been to tell patients to wash everything, which is a crazy ton of work, to wash all of their bedding, to wash all of their towels, to wash any clothes that they've worn in the last couple of weeks. And we've never had objective data until the study that came out a few years ago, where it was actually very impressive when I think about how much work it was to do. They looked at over 5,000 adult mites and over 2,000 eggs of the scabies mites, and they exposed these mites and eggs to 89 different conditions. And they found in order to actually kill the scabies mites, you needed to expose them to a lot of heat, so greater than 50 degrees Celsius or 122 degrees Fahrenheit for at least 10 minutes. Fortunately, a home dryer on a high setting is 130 degrees. You could freeze them out minus 10 degrees Celsius, but that's a little tougher to put them in the freezer, and that would be over 5 days. The other thing you could do is put them in a closed plastic bag and put their clothing off to the side. And depending on the climate conditions, in a sort of a normal temperate climate, within 4 days, they would die. But if a warm, humid climate like we're having in New York right now, it can take 8 days to kill the mites. So I usually tell patients, just an abundance of caution, to put everything aside for 2 weeks. But now we have objective data that that's a good idea. So summarizing, the scabies is caused by the scabies mite. It is species specific. Dogs do have their own scabies mite, which can occasionally bite humans, but that's just a bite. They don't want to live there. So this, by definition, if a patient has scabies, is the human variant. Super common, of 1 million people per year are diagnosed with scabies. It's spread by direct skin to skin contact. If you're a friendly and outgoing clinician and you shake somebody's hand, it can take up to a month or even 6 weeks for you to start to be itchy. The differential with this is other things that can be very itchy, such as insect bites, eczema, and a condition called dermatitis herpetiformis, which is super itchy and associated with celiac disease. The treatments we talked about, the permethrin lotion applied the neck down, making sure that they are really careful about it, repeating in 1 week. The other option is the oral ivermectin. I have the dose here, 0.2 milligrams per kilogram. It comes in 3 milligram pills times 2 doses, 1 week apart. Treat all contacts. It's fascinating to me that somebody might be sleeping in the same bed and not have any scabies, but they're certainly at risk. And we were looking at a nodular variation of scabies, and just I didn't bring the photo, but just a reminder that if you see nodules on the penis, they are scabies until proven otherwise. Okay, let's keep going. I think we have a little more time. This is a 20-year-old, otherwise healthy female who came in with this hyperpigmentation on her face of several weeks duration. You sound very smart if you figure this one out. What we're seeing on her face in the perioral area are these hyperpigmented macules and patches. They don't seem to have any surface change with these kind of very bizarre geometric shapes. They're linear. They're a little more confluent on the upper lip. On the right side, they are just have these kind of weird angles and sort of kind of unusual geometric shapes. This doesn't look like the rashes that we've seen before. Do you guys have any idea what this might be? And I'm so sorry, I can't see the, oh, there's the chat. Some form of contact dermatitis is you're right to be thinking that because of these unusual geometric shapes, you're thinking this must be an outside job. This is a condition called phytophotodermatitis, and it's considered a phototoxic reaction. So what you need in this condition to have it is you need an exposure to the toxin. In this case, it's a plant-based or a fruit, and you need exposure to UV light, which most commonly is UVA. The classic story with this is, let's say our patient went on spring break and she was having a Corona with lime out on the beach, and she took the lime and she squeezed it to put it in her beer, and she squirted some of it on her face, and she's outside and getting exposure to UVA light. And the rash might have been really subtle, but this rash is notorious for healing with this post-pigmentation. The pigmentation can last for quite a while. It's really difficult to treat with our topical medications. I wanted to show you some other pictures of this. But it will self-resolve. There's a number of different plants that can cause this. Some of them are herbs like parsley. I once had a patient that went on a vacation and she was walking through a garden and picking up herbs and smelling them, and she got some of this on her hands. This is another example of it. Sometimes you can catch the inflammatory phase, but again, these are very streaky, really bizarre shapes. In skin of color, the pigmentation can be even more striking and even more difficult to take care of. Again, very streaky, unusual shapes, but you sound very smart when somebody comes in with this phytophotodermatitis and you start asking them questions about their exposures. Usually you can figure it out. These are 2 tables looking at the plants that can cause this. The most common ones that I tend to see are on the right, which is lemons and limes. I saw a patient with outside drank a Bloody Mary with a celery stalk sort of sitting vertically, and she wound up corresponding to the celery stalk with this sort of vertical linear hyperpigmented patch on her upper lip. And a few months ago, I had a MAVEN consult with this condition, and she was super excited to try to figure it out. So this can occur in anyone. It's not a true allergy the way a poison ivy or a nickel allergy would be. It's a phototoxic reaction, meaning you need the toxin and you need UVA light. It's caused by accidental exposure of the skin with the sap from the plant, followed by the sun exposure. The plant's the actual ingredient is called a furocomerin. And when it's exposed to UVA, it actually can damage the cells and lead to the inflammation. But that inflammation can be really subtle and sometimes missed. And this characteristically heals with pigmentation, which, especially if you keep getting it in the sun, can last for years. The differential was right, what you thought about of a contact dermatitis, of an injury from a burn. If you still see the inflammation, you can treat it with topical steroids. And the treatment is really compulsive sun protection and time, because eventually this will fade. But these pigment cells are perfectly happy to make pigment, and they're going to keep doing it if you keep going. The reason for the words broad spectrum is the number on a sunscreen typically refers to UVB exposure. And the FDA, the only way that you could tell that a sunscreen is, will also cover into the UVA spectrum if it has the words broad spectrum. The UVA is set a threshold for UVA exposure. Europe's a little different. They actually have a star system, 1 through 4 stars, to show the UVA exposure. Okay, next case. This is a 22-year-old woman who has a sudden onset of the pretty painful and somewhat itchy rash on her face. She looks like she's probably a little miserable, and around the eye there is some edema. But what's most striking about this are these fairly monomorphous. One lesion looks pretty similar to another, well circumscribed, round, crusted erosions. Some of them seem discrete, some of them seem more grouped together. And if you look very closely, maybe you can see an intact vesicle, but most of these are past that stage and they're more punched out, tiny little erosions. The background skin doesn't look normal. If you look at her upper eyelids, you can see some erythema and you can see some lichenification and fine scale. So you guys have any ideas what this might be? So zoster is one thought. Herpes simplex is another thought. But you're on the right track of being a herpetic infection. In the setting of an otherwise inflammatory condition, the most common is atopic dermatitis or eczema. This is called eczema herpeticum. And the herpes virus can spread like wildfire on the skin, and it can be really extensive and generalized and can be pretty severe. We don't have a whole lot of dermatology emergencies, but this is one that you want to get a patient in. If it's pretty extensive, you want to treat them with systemic antivirals and perhaps do it with intravenous acyclovir for a couple of days until you get this under control. Besides just having these extensive open areas of skin, which can be a nidus for secondary infection, rare complications of the herpes virus include a viral pneumonia, and the most serious would be a herpes encephalitis. I used to work for a number of years at Sloan Kettering, and we actually had a patient with graft versus host disease who developed this eczema herpeticum with very widespread crusted erosions, and he was significantly immunosuppressed. They were treating him for blood cancer, and he actually died from that. So this can be a serious infection that warrants attention. You don't always get to see the blisters, and the reason for that is the virus is invading within that epidermis, the top layer of skin. It's causing the cells to swell and to break off from each other, and so that roof of the blister isn't very thick, and it's very easy, especially in somebody that has an itchy condition, for that roof of the blister to be gone before you actually see it. And and that can lead to you're seeing more of lesions that are just an extra few days old that are a little more crusted. If you look very carefully at some of these spots, you can see the edge where the blister was. You can almost see that little rim of scale on some of these spots. One of the things we talk about when the herpes blisters are quite grouped is, if you can imagine where the blisters might have been all grouped together, is it leaves this border that is almost like the top of a scallop shell, sort of little curves and indentations. And that can be one of the characteristic features that your eyes naturally went to when I asked you guys what this was. Um, thinking about that this might have been a blistering condition, even though you don't see the actual blisters. Computer illustration. I'll show you other pictures of this. Right, there we go. So this is a much more severe case of it. You can see how extensive this is, but still these grouped, pretty monomorphous crusted erosions. Here's another case of it. Here you can see where you can imagine in some of these spots where the rim of the papule is a little bit of an elevated rim, and that might have been where those edges of the blister are. Here's another case of it. Again, you're seeing a little bit of lichenification or thickening of the skin underneath it, so the skin is not normal. I brought this to contrast the case that we're looking at. Does anybody know what this is? So this is classic bullous impetigo, and it's common for eczema herpeticum to get a secondary impetigo because you have so much open skin, and staph is such a common colonizer in patients with eczema. But this has that characteristic honey yellow crust and scaling to it. In terms of the ophthalmology consult, yes, I absolutely agree that you would want that because the lesions are so close to the eye, and herpes can very much affect the conjunctiva of the eye, leading to scarring and blindness. So in this case, you definitely would, even though this is a herpes simplex infection. I showed you a very limited picture of the area, and so if you so herpes zoster in the V1 distribution would have also been fair game. And in that distribution, you definitely want to make sure you're getting an ophthalmology consult, even if the eye looks okay, because you definitely want to protect the eye as much as you can. Okay, well, I'm trying to figure out computers. Do you guys have any questions of things we've talked about so far?
Would they also require an urgent ophtho eval?
So in this particular case, I would, because the herpes lesions are so close to the eye. If it was someplace else on the body, I don't think that would be necessary. One of the differentials of this, based on the photo I showed you, was B1 herpes zoster, and that B1 herpes zoster, even if around the eyelid looks totally normal, does require an urgent ophthalmology consultation. Sometimes they'll add prednisone. They'll add things to try to protect the eye, and they'll certainly follow closely for any signs. Okay, this would be a case where you look at it and you would say this is impetiginized eczema, but if you look closely now that you're sort of clued in, you can see these kind of monomorphous grouped papules. In this case, they're crusted with this extensive honey-colored crust, so there's also secondary bacterial or staph infection. You want to make sure you cover for that. But this would be a patient I would consider admitting to the hospital to get intravenous medication. So this can be seen with other disorders of the skin barrier, such as seborrhea, ichthyosis. It tends to come very suddenly. You go sort of 0 to 60 pretty quickly with these punched out spots. They tend to be more painful than itchy, and it's caused by disseminated herpes infection. As we talked about, you often don't get to see those blisters. Patients are pretty miserable, and you want to get antivirals on board as quickly as possible. Okay, I'm going to end with this. We're going to blast through these. Turns out when I talk to my colleagues that see patients at the hospital, one of their common consultations is for cellulitis, why it's not getting better. And somebody wrote a paper looking at this, and it turns out that at least a third of cases that are admitted to the hospital cellulitis really aren't cellulitis. So this has become a pet peeve, both of myself and many other people. So I'm going to ask the question: is this cellulitis? And if not, what is it? So in this picture, I'm seeing bilateral on the lower distal lower extremities. Um, erythematous, extensive patches covering most of the distal lower leg and approximately a few erythematous macules. There seems to be some scale here. There seems to be some edema. There seems to be poor venous circulation with a lot of little spider veins here, and it's bilateral. So stasis dermatitis seems vascular, absolutely. Um, Pretty much by definition, bilateral means that it's not cellulitis. The idea is that you could have bilateral cellulitis at the same time is pretty much impossible to have. I'm so sorry, guys. Stasis dermatitis is really common, especially in older people. The veins in our legs have this really tough job to do to go against gravity. Okay, next case. Is this cellulitis? Here we're seeing skin that seems pretty abnormal. If we touched it, these would be pretty firm plaques with overlying erythema and scale. The skin is firm and somewhat thickened. The background surrounding skin has some erythema and scale. Is this cellulitis? Definitely red. So this is late. This is not cellulitis. This is a late stage of stasis dermatitis. It's called lipodermatosclerosis, and the skin starts to get like very firm and bound down. Definitely vulnerable to cellulitis, but often there's a lot of erythema with this. But given that the edema and the erythema, it's easy to confuse it with cellulitis. Cellulitis would be warm, it would be tender, and the patient might not feel well. Is this cellulitis? So here I'm seeing a solitary bulla, so a large tense blister or bulla. The surrounding skin doesn't look terribly abnormal. It's skin of color, so maybe there's a little bit of erythema surrounding it here, but it is a pretty large blister. So what do you guys think? So it is not. Does anyone know what it is? So this is a bullous insect bite or arthropod bite. Sometimes you can get so much swelling with an insect bite that the cells in the epidermis, um, uh, the edema coming between them just pulls those bonds aside, um, and uh, and it can lead to a tense blister. Sometimes there's some surrounding redness because it is a bug bite. And I've definitely seen people come in with this, and usually if they've been to an urgent care, they are on some form of an antibiotic for cellulitis, but yet it is is just a blister. Excuse me, it is just an insect bite and symptomatic relief with ice and topical steroids and calamine and Sorna. Definitely make patients feel more comfortable. Do you pop the blister? Is that going to be something that's helpful to the patient? No is correct. And the reason for that is this is not an infectious blister. It is sterile. And right now, when we have the roof over it, it is offering a nice dressing. If we pop this, it can reform and then leaves the patients more vulnerable to vitiligo and secondary infection. Frozen, and I think we're just about out of time. So I'm going to stop here. Any other questions that you guys have? All right. Kristen, thank you so much for inviting me. I apologize about the technology. Still not sure why it didn't work, but thank you for hanging with me.
Oh, no problem. And if anybody thinks of a question afterwards, please remember you can always use the e-consult platform. Um, yeah.
All right.
All right.
Thank you guys so much. Have a great day.
All right. Bye-bye.